I have the honor to introduce our other honored guest speaker, Steve Lewis. I've known Steve for many, many years from Toronto. Really an expert in all aspects of spine surgery. I remember one time I was very deep into a discussion with him about deformity, and he's like, "Oh, let me show you my spondylectomy technique." So Steve's really well-versed in all aspects of complex cases, and he has been a real leader in AO for spinal deformity and has led very successfully the AO Knowledge Forum in deformity for many years. And really tremendous contributions there coming out of that group, both in PEDS and SCOLI risk. So thank you, Steve, for everything you've done with AO Knowledge Forum for deformity, and I'm looking forward to your talk.
Thanks for the honor of being here. I had the honor of being in Hawaii with you guys as well, and to see the impact that you guys have both locally and around the world and around the country in terms of training and everything is really quite impressive and a nice model for us to see. So thank you very much, and thanks for having me. And it's nice to know that the struggles that we have are similar to you guys' struggles what we see in our cases as well. So I'm going to talk about the differences in between when to use a PSO, when to use interbodies, and this is kind of a case that really changed a lot my career a lot, and is a flatback deformity. We measured all her parameters, and she needed a ton of lordosis, so we did a standard L3 PSO with some interbodies, F4, 5, and 5-1, and she's probably one of my most unhappy patients because her tummy stuck out so much. And for her, it was such a big problem that I actually had to undo the osteotomy for her to get her straightened out. And so we ended up going to the front and taking out the top of 3 and the disc of 2-3. And then I had to break the posterior column and distract it in order to undo the PSO, which she probably didn't really need. Probably all she needed was some pretty good interbodies at the bottom. And so this was really taught me a lot about distribution of lordosis, and using this global parameters that we use is really not very good. You know, you look at the numbers at the time, they were ideal. We published her case report in 2010, I think, just to go over, but it really had a big impact on me, and knowing that really doing the osteotomy in the right spot is just as important as doing really understanding the early alignment. And so when do you do a PSO? When do you do an interbody? Some of the considerations that I use. First of all, how big a deformity you have. Where is the deformity? How flexible is your anterior column? How many levels can you actually rely on to get correction? And what kind of compensation are you seeing through the legs and through the rest of the spine? So all these are some of the things that we have to think about. And then obviously the magnitude of the surgery and the morbidity of the surgery that you're going to have. So we have some alignment goals, and I find ankh spawn really an easy one for me to use just because it's so black and white. The whole spine's fused, nothing's going to move. And so you look at it, and one of the big papers that I was from my mentor, Bridwell, who had some fellow measure every x-ray at every level and come up with some numbers that probably are not 100% right, but the distribution is very good. And you know, if you look at this patient, it's very easy. You can see that his thoracic spine looks not too bad. His thoracolumbar looks kyphosis, and he doesn't have enough lumbar lordosis. And so really for him, 2 PSOs in those areas are going to correct what you need. And so really the ankh spawn is kind of straightforward, and using some of these distributions that was written in 1989. I'm not sure how much smarter we are from this with all the extra knowledge that we have. It really helps. And then, you know, you have the newer version from 2017 from Pacenti that was also shown. And I you know, again, 2/3 your lordosis is going to be from 4 to 1. And he came out with a constant about 35 degrees. When we looked at the mean data, it actually wasn't about 35, but it probably ranged from 30 to 40, depending on the PI. And then the distribution was really good because he measured actually at every level. And so you can see for him, in them for a low PI, easy numbers to remember, 1, 5, 10, 15, 20 gets you probably through the low lumbar. And then with the high PI patients, perhaps they have a little one inflection point higher, so maybe you have to go higher, so you can go 1, 5, 10, 15, 15, 20 for the last 6 levels instead. and you can see just that shift up. But at the end of the day, having this distribution really helps you know what you're trying to achieve. And then, Mike and Jeff brought it a step further using some of the means data, coming up with the L1 PA and the T4 L1 alignment guide, which really has been very helpful for us to see, and really works quite nicely to know roughly what you're trying to achieve and what you're trying to achieve with your patients. So when we look at these degenerative spondies, I find that the ones who have degenerative disease in the lumbar spine, most often they lose their 4-to-1, and how to get it back or how to ignore it is hard to deal with. This is a case that I had early in my career that also one of these kind of sentinel cases for me is a guy came with a disc herniation, and we ended up doing a discectomy. He did pretty well for a while, and then we fused him. But you can see we fused him with very little lordosis at 5-1. And then, of course, you can see the hyperlordosis going on at the higher levels, 4-5, 3-4, 2-3. They're all very hyperlordotic discs. So he came back, and we ended up fusing his 4-5, and again in kyphosis. And you can see, again, the hyperlordosis at 3-4 and 2-3. And then the question is, do you do something big now at 3-4 wearing out or not? So, of course, we just fused 3-4 with extra lordosis. We fused his SI joints, and he got to the point where now his L2-3 is not happy either. So we ended up having to take a step back, and you say, are you going to keep going? But at the end of the day, his biggest problem is this degenerative lordosis from 4-to-1 with the, I think he had about 15 degrees of lordosis between 4-to-1, which is not acceptable. And when I looked at it, you look at it, where's his location? His deformity is only at the bottom. The magnitude is about 20 degrees. Is he flexible through that anterior column? No, he's not. How many mobile segments? Well, they're at the higher levels. Do I really want to compensate through there? And then you need really, at the end of the day, if I'm going to go higher, am I going to keep this cascade going, or should I take a step back and fix his lordosis? And that's what we ended up doing. We kind of extended him one higher, but we did an L5 PSO for him, and you can see the difference in the hyperlordosis. The discs leveled out nicely. We got nice alignments in terms of his T4 L1 and his L1 PA more in a normal match, and hopefully I won't have to keep adding up higher for him. Another one with a fused anterior column is a post-burst fracture that was treated with a posterior type of procedure in kyphosis, and you can see he had an anterior posterior with a fibular graft done way back when, and you can see it's pretty clear. I'm not going to get much compensation through the bottom. If you go back, you can see he lordoses his thoracic spine, so he's probably an ideal candidate for a 3-column osteotomy. I'm not sure I could get enough deformity correction through 4-5 and 5-1, especially from the back. I'm sure some can do a nice anterior approach at 4-5 and 5-1 like Manish and get the correction. We ended up looking at him and saying, well, he's solidly fused. I don't think I'm going to get a lot from the bottom. And so we ended up doing a PSO through his fusion mass, which we describe with the central rod for closure. And you can see we got a pretty nice correction. These are the older x-rays because the case was done a long time ago. But you can see on CT, focal correction, a nice balance with the spine, and you can see the kyphosis comes back in his thoracic spine after. So what happens if you have a mobile anterior column? Well, those are completely different. So you can see a very severe deformity, much worse than his, completely uncompensated, but you can see that the discs are wide open, and this is going to be a very flexible spine. You really don't have to go crazy on doing any major osteotomies. You can do this from the front, from the back, interbodies, front, back, and really it's not going to make a big difference. You can see it corrects quite nicely on CT scan when he lies down, and the discs are wide open. This is not something that's going to be a big struggle in terms of correction. We can do this all from the back. We did some posterior-based interbodies and corrected them through, even though it's quite severe. This is probably where you can use your CT scan or your supine x-rays to see that there's not going to be a deformity that's going to need a lot of work. Now, this was an interesting case I did. Someone sent me, they did the Sherman's kyphosis on a 21-year-old, and so I revised him, and this is what we got. We got pretty happy, and he presented 11 years later with advanced degeneration from his 4-5 and 5-1 discs. And you can see air in the disc, so I thought it was going to move a fair bit. He looked really off in both his coronal plane and sagittal plane, a little bit off on some of his other alignments higher up. But at the end of the day, I thought I'd be able to get him back to this quite easily. And with a posterior, I wasn't able to. And this is what I ended up with Tried really hard with posterior-based interbodies and releases, and you can see he got obviously much better, but he's probably undercorrected. And this is something that perhaps you have to take a step back and say that he needs something a little bit bigger. We did some osteotomies through his thoracic spine to balance it out a little bit better, but you can see he's still undercorrected through his posterior column, and we'll see how that works out in long term. I had a lot of these older degenerative patients, and you can see these air in the discs, a solidly fused 5-1, and then how aggressive to you be. I think this is one that Manish can do a very nice job with multi-level anteriors. We did a posterior-based procedure for him, so you can see he's got severe, probably upper mid-lumbar kyphosis. 4-to-1 is close to 0, and he probably could use a little bit more. So we ended up focusing perhaps most of our at 2, 3, 3, 4, trying to get an interbody at 4, 5 to see if we can correct him out. And then with this guy here, we just did Smith-Peterson osteotomies with over-contoured rods, and you can see that we got some correction, and perhaps these slightly undercorrected deformities, but correction is good enough. And then probably we're going to try to look at our series of these done well, partially corrected patients, and is it good enough, and how close do you really need to get in terms of your alignment, risking surgical complexity in order to get what you need. A similar case, and you can see here, he has a fair bit of 4-5 lordosis, again, a mid-lumbar kyphosis, treated with just a interbody at 4-5 and some Smith-Peterson osteotomies, which I do a little bit different than you guys. I leave the inferior facet and I take the superior facet because I think the superior facet is really where the money is. It's where the ligaments detaches it from the pedicles. You get a lot more mobility. The inferior facet actually doesn't do very much in my hands, and so we always try to leave the inferior facet for bone stock and work underneath it to get the superior facet detached. And you can see here we've got a pretty decent correction on him. Still perhaps a little bit under contoured, but overall a pretty well balanced spine for him. And then looking at when should you do more, when does more need to be done. We did overcome a fair bit of deformity for him through what looked like a fixed segment without needing to do anything from front to back or 3-column osteotomy. I've had cases where you can see the deformity so great that one osteotomy is not even enough. And you can see, we looked at her, she has a gross coronal and sagittal malalignment. She's pretty flat at the bottom, but really driving force is this major deformity up at the thoracolumbar junction and upper lumbar. And so we ended up doing, I do these hemi PSOs, which we take out just through the apex, go through the, we described it for a late Lenke 2, but we did it here for her case, and I have a big series of cases where we do these hemi kind of PSOs or VCRs, where you just take out, do a Smith-Pete on one side, do the osteotomy, 3-column on the other side, and you can see you get a really nice correction through her, but you can still see she's, the coronally, we ended up getting her nice and straight. No PJK on the initial intra-op x-ray, but PJK about 10 minutes later on her first standing x-ray, and then we ended up driving that for a little bit until we ended up having to do a L5 PSO for her and extending her up into the T4 region. And I haven't had PJK for her she's about 3 years out now, despite the T4 top UIV. So are there problems with undercorrection? I had this patient here that I inherited with a solid fusion. You can see that very mobile disc, but he's completely flat. And then he ended up with degeneration above and below. And this is kind of the common situation with these undercontoured patients. This is another case that I just inherited with a degenerative deformity, fixed a little bit flat. And you can see he has a pseudoarthrosis at 5-1 on top of everything. And so we ended up fixing his pseudoarthrosis and extending him a little higher. But it didn't take long. He ended up with a acute disc herniation and myelopathy at the top end. And we had to take him back. You can see that right there. And extend him. And so once we can extend him, we took the opportunity to do a L5 PSO for him to realign him at the same time. And so we ended up with a extension to T4 with an L4 PSO, which we just did last week for him, and he's done well in the early follow-up, trying to realign him as a main cause of his kind of undercorrected. So he's kind of these undercorrected deformities that the odd one that you have to come back on. And I'm not sure if that represents 20% of my cases or 75% of my cases, depending on how long you fall, but that's something that we're going to hopefully have an answer for soon. So in summary, really you have to look at all the different considerations for your patients. Where's the deformity? How big is the deformity? How flexible is the deformity? How many mobile segments you have to work with, and what kind of compensation you're dealing with the spine. On top of that, you have to balance it with the morbidity of the cases that you're trying to achieve. You should have some segmental and global guidelines. I think it's kind of important. When you set up your hockey team or soccer team, you're not expecting your defenseman to do most of your scoring, and I think everybody has their job when you set up these things, and I think the same thing goes for these levels. Each level has their own job, and I think when you're trying to make levels do jobs that they don't work, and you end up with different problems. So undercorrection may lead to higher junctional failures. 3 PSOs carry higher morbidity risks. There's limited correction you can do with a posterior-based interbody, so you have to know the kind of limitations. ACRs, laterals, A-lifts, all may provide some greater anterior column supports than you can achieve with posterior-based, and basically restore your alignment based on your guidelines that you have. Thank you very much.
Great, Steve. Questions for Steve Lewis? One question I had for you, and I know AO's doing some great work in this area as well, is about your rod configurations. I saw a lot of different satellite rods, occasional double pelvis, especially for PSO versus interbody. How do you decide on all that now?
So in the past, I've only been one rod on each side, and we actually published our series of 80 3-column osteotomies. I only had 3 broken rods at the osteotomy site. So, and that's because we restore the posterior column. I fix it really well. But having said that, we've had a series of these late broken rods. I would say that a lot of them break 10, 11 years, 4 years later, whatever, but they're actually not pseudoarthrosis, they're fusion mass fractures.
Mm-hmm. Right.
And you can see these transverse fractures right through the fusion mass. Often they're levels that don't have maybe the same screw density. They're levels that have higher disc spaces kind of in the upper lumbar, and we see these transverse fractures. So we just reviewed my last 50 broken rods, and 30 of them were fusion mass fractures as opposed to suit. So I think the importance of more rods is I think definitely something that I've moved to, and so my new constructs all have multiple rods.
Yeah, that was such a lie that we were told growing up in spine surgery by the old spine surgeons, which is that you'll never get a rod fracture if you have a solid fusion. That is completely a lie. We were told for so many,
yes.
so many years. So maybe you could just summarize, what do you do for PSO now? Do you still use just 2? You always use 4? You use 6?
It depends.
The ribs, like what?
Yeah, so all of them have posterior columns reconstructed. So I do not leave a gap in the posterior column. And so if I do a thoracic osteotomy, if I get bone on bone, I'm fine. If not, I'm going to reinforce it with structural bone. And so there's structural bone across each site. So that is covered. And then now I'm covering at least with one side with I like the dual-headed screws. Mm-hmm. And so then I just send a rod on the extra screws. I don't like the connectors, because the connectors sit in the facet joints, and I think you don't get as good fusions if you have connectors in the facet joints. So through a fuse segment, I don't want to put in a connector, but through a virgin spine, I'm trying to fuse the facet. I try not to use those, so I like the dual-headed screws. But so I would say that lumbar PSO, I'm going to be putting 4 iliac screws. So there'll be 2 SIs and then a iliac, and then I'm going to run double-headed screws and run rods that'll bypass the osteotomy sites.
And how about cases where there's an extensive laminectomy, or maybe you don't do that? What is your rod configuration there? Do you use any extra rods, or?
I'll still fill the posterior column for fusion, and then I'll protect it with a second rod, like you said. So I've gone from a pure one rod on each side to basically selective protection with, especially going down to the bottom, especially after seeing so many of these late broken rods from solid fusions.
Any other questions for, Manish?
You know what Steve is not telling you is his carpentry. You have to see his carpentry. You have to see the. If you have you ever have a chance to go see him, you should see his OR work. So he carefully delineates the osteotomy, and then he makes sure there's bony contact. He's very modest, he won't tell you, but he makes sure that there's plenty of bony contact and also covering with bone in the back. And that's the key to his success. That's why he doesn't have the same amount of rod failure as the rest of the population.
All right, thanks, Steve.